Thank you for joining us. My name is Megan Auclair. I am with the Oregon Health Authority. Just want to welcome you all to today's event, which is a discussion around designing the proposed 1115 waiver. I'm going to be facilitating today's session and keep us on time, introduce speakers, and read questions from the chat. We're also attempting to get some questions that we can unmute folks so that they can ask questions directly. I will let you know as we are able to unmute and offer that opportunity. So our agenda for today, we're going to go through some opening remarks from Jeremy Vandehay, who is the Director of Health Policy and Analytics. We're going to go through some policy deep dives on some proposed ideas for the waiver. We will have an opportunity within each of those deep dives for some questions to be asked. We'll have 15 minutes of presentation and then 15 minutes of questions. We've also got an optional additional question and answer period at the end of the session. No one is required to stay, but we do have some extra time available there. And then after the Q&A session, we will have an optional feedback session in addition to that, if folks would like to have additional discussion. So just a few little housekeeping rules for today. I do need to inform everyone that this session is being recorded. We will have a link to the recording posted on our website, which we will put into the chat, and also have the information available at the end of this slide deck. We do have everyone muted for today's session, so my ask is that if you would please enter any questions that you have into the chat box. Like I mentioned before, we will be looking into being able to unmute folks who have questions. If you can use the raise your hand function. So at the very bottom of your screen, you should be able to see a button that says chat. That's where you can click and enter questions. So as far as additional housekeeping rules, OHA's contribution to today and what we hope to facilitate is a robust discussion around the 1115 waiver project. We are going to capture all of the questions and comments and make sure that anything that we don't get to today, we are able to provide a response. Our goal is to provide a written response by the end of next week, so by June 4th. We like to compile those questions and post them on our website so that we make sure that we answer any questions that come up. The thing that we would ask of you is to please participate in an open conversation about the 4 focus areas and be respectful of the privacy of our participants. As I mentioned, we will be collecting questions in the chat box, and we will be reading some of them during the session. And as I mentioned, if we don't get to some of them today, we will post responses by June 4th. What I would ask is that if you're putting questions in, please include your name and the organization that you're representing, if you're from an organization, and I will be reading that information as I read the question. At the end, we'll have more information about how to stay engaged in the process and information about our webpage, which is accessible in both English and Spanish. Okay, next slide, please. So I will hand it over to Jeremy Vandehay, who is the Director of the Health Policy and Analytics Division. I'm here with the Oregon Health Authority. Jeremy?
All right, welcome everybody. I'm looking at the participant count. I think everybody was on for the first one, so I will just dive straight in. Next slide. As we talked about earlier, and I'll just say one more time, the waiver is a really critical part of defining how we run the Oregon Health Plan, but it's not the only part. It's not. It doesn't provide all of the rules for how Medicaid's run in Oregon or how CCOs are run. A lot of that is through our normal contracting process or normal rulemaking, and the waiver is really focused on places where we need federal responsibility, or excuse me, federal flexibility. Um, uh, as we were going through this process, again, we don't expect everybody to understand what needs to go in a waiver and what doesn't need to go in a waiver. We're looking for input and want to know how to make the Oregon Health Plan work better for members. Some of those things may be things that would be appropriate for a waiver, and some of those things may be issues that really we can address outside the waiver. But we'll be collecting all of that, and for things that are non-waiver issues, we'll be feeding those into the parts of the agency where they can be best addressed. This timeline shows the overall trajectory for our waiver work. Our waiver our last waiver was approved in January 2017. It was for about 5.5 years. It expires next summer, June 30th, 2022. Normally you have to apply about a year in advance, but given COVID, wildfires, a lot of other strain in communities, the federal government's given us some leeway to be able to apply at the end of this year instead of during this coming summer, which gives us about an additional 6 months to get public input and to be able to draft the application. It's still a fairly tight timeline. Nobody was expecting a pandemic last year, so we actually thought we'd be kicking off our waiver work about a year ago. We're still on track, and we'll meet our the federal timeline of applying by the end of the year. But do you want to recognize it's a more condensed timeline to submit the application than I think what we had hoped for before the pandemic and before everything that has got thrown at communities over the last year. That has led us though to think about what public engagement looks like for the waiver process, and the approach that we're taking is rather than going out with sort of a blank piece of paper, it's really to take the feedback we've received over the last couple of years through a number of different community engagement processes, through development of the state health improvement plan, through input through the CCO 2.0 contracting process, which was the last procurement that we went through with CCOs, through input we've received throughout the COVID-19 response, and community input we received there, and to start with compiling input we've already received from communities around where the problems and challenges are, and then to put some proposals together that we think are issues that require a federal waiver, that would help address those issues. So we're trying to start from a place of information we've already heard from communities, and then get public input on are we on the right track. Where we are right now is we've spent the first part of this year building out our team, launching it, doing a lot of kind of waiver background presentations with folks, and identifying our key vision and goals with governor's office, legislature, Oregon Health Policy Board, and others. We're now entering the first phase of public engagement, where we're going to be getting input on some ideas that we're putting out there in response to input we've received over the last several years. That will happen through the spring and early summer. We'll then be going into drafting an actual application by the end of the summer, and that will kickstart a second round of public engagement and tribal consultation on that draft application. We'll make changes before submitting it by the end of the year. And then the first 6 months of next year is really a process of negotiating and information sharing with CMS on what we've proposed, and what they're comfortable with. What we get out on the other end won't look exactly like we applied. It's a negotiating process, and the federal government has very broad discretion on what they can approve, and they also have limitations on what they can and they can't waive. So a lot of that comes out through the one-on-one dialogue that we have with CMS after we've submitted our application. I want to go to the next slide. So we spent the late winter and early spring, again, compiling community input we've received in previous processes, trying to really get clear on some of the problems that we think could be solved in a waiver. Again, not everything that is a challenge is something that a waiver can address. And and some of them are frankly issues that we just need to address locally through our relationships with the delivery system. So we're looking for those things that really need some adjusted federal rules and federal flexibility in order to address. We've compiled those into some concept papers that we'll be releasing next week that outline some of our key goals and the problems we're trying to solve, and some initial strategies or promising strategies for addressing those challenges. We'll be wanting to get feedback throughout June on that, and then we'll plan to release revised concept papers in July. And then over the summer, we'll turn those concept papers into a draft application, and then that draft application will be available for tribal consultation and public engagement and comment late summer, early fall. Next slide. I want to go to the next slide. So let me just hit at a high level our overall goals for the waiver. And then we'll spend the rest of the afternoon talking about going a bit deeper into each one of these and talking about some of the key individual strategies. Our overall goal for this waiver is to advance health equity and to have the waiver be a key tool for our 10-year goal as an agency to eliminate health inequities in the state by 2030. That was a goal that we, as a leadership team within OHA, had adopted just before the pandemic hit, and COVID has really highlighted how critically important it is that our focus as an agency be really laser in on health equity. We've spent a lot of time over the last decade talking about the triple aim goals of improving quality, improving health outcomes, and lowering costs. We've done a lot of great work in Medicaid and in other places to do that. But what we've really seen is that disparities and inequities have persisted. To give you an example, we've seen that within coordinated care organizations, quality has improved in areas where we've been paying CCOs for certain quality improvement. But when we break that data down by race and ethnicity, we see inequities that predated CCOs that have persisted through. So we really see that we need to take a step back from just talking about the triple aim generally, and really make a concerted effort to specifically address inequities and to move us forward as a state on health equity, and ensure that all Oregonians receive the same level of high quality care and have the same opportunity to reach their full health potential. To that end, there's four key areas within with sort of four puzzle pieces that we've mapped out that we think fit together to really advance health equity through this waiver over the next 5 years. The first one is first ensuring that we're continuing to move towards all Oregonians having access to affordable healthcare coverage. Being able to get the healthcare you need is sort of dependent first and foremost on having insurance. And the Oregon Health Plan is a key part of the overall insurance market in the state. It provides healthcare coverage for about 25% of Oregonians. That's increased. We've had about 200,000 people come onto the Oregon Health Plan during the pandemic over the last year. And there's certainly pieces outside of Medicaid that are important to address to be able to get to universal coverage. But we think there's a lot that can be done on Medicaid as well. You'll hear a little bit more about this when we talk the deep dive. But in essence, we have about 94% of the state with insurance today. But that number is the uninsurance rate is much higher for certain populations. 12% of Hispanic Latinx communities, as an example, are uninsured. And so first and foremost, to be able to address health equity, we need people to have insurance so they can access the system. The second component is really moving towards an equity-centered system of health. So once people have insurance through the Oregon Health Plan or other places, we need a healthcare delivery system that's really centered in health equity, that promotes health equity, that that is focused on reducing inequities, eliminating historical racism within the system, and making sure that all Oregonians have access to the care that they need to be healthy. The third area is around more flexibility on how healthcare dollars are spent to be able to address the health needs of individuals on the Oregon Health Plan. We have had as a key strategy within our coordinated care organization model the idea of global budgets, the idea of blending various Medicaid funding streams together into one budget that's flexible for the community to be able to spend in a way that best meets the needs of those on the Oregon Health Plan, and grows at a fixed sustainable rate of growth that also keeps healthcare costs in check and not outpacing the rest of the economy. We want to continue to evolve the way we pay CCOs to encourage more investments upstream and in places that reduce downstream costs. And so want to keep evolving that global budget concept in a way that provides more community flexibility, more incentive to improve health, and also does it in a way that is financially sustainable for the state. That leads into the fourth area, which is if we are successful in improving health, if we're successful in smarter spending in communities in ways that focus on prevention, as an example, that should lower healthcare costs, and that should help us keep cost growth of the Medicaid program in Oregon lower than national projections. And if we're able to do that, we'd like to see if we can share some of that savings with the federal government and put those dollars into some places where we need to actually make some targeted investments to address inequities in the state. We know that there are systemic problems. There are places where we need to add dollars if we want to be able to be successful on addressing health equity. So those are our four areas. We're going to now spend the rest of the time diving a bit deeper. And I think I'm turning it over to Tim Sweeney at this point.
Actually, let me jump in real quick. We've got Lori Coiner, our Medicaid director, who'd like to jump in for just a moment. Lori, are you unmuted?
I am now, thanks. Let me turn my camera on too. Good afternoon, everyone. I just wanted to say hi. So I'm on, and I will be with Jeremy at the end for a Q&A later on. Thanks.
Thank you, Lori. So let's go ahead and hand it over to Tim Sweeney from the Office of Health Policy. Tim, let's jump to you to discuss coverage.
Great, thank you. And just a hair bit of background, as Jeremy mentioned, the first strategy is increasing the number of people who have coverage and kind of maximizing our eligibility for the Oregon Health Plan. And really, as Jeremy mentioned, all of the programmatic success we are trying to shoot for in the waiver really is dependent on people actually getting enrolled and staying enrolled in the program. So we have a handful of strategies trying to maximize coverage and get as close to 100% coverage in Oregon as we can. And we'll start with, in the next slide, just a couple of the, sort of to ground this back in the member experience, what we've heard from people. And certainly I think this first one is a big issue in the healthcare system, is as folks go back and forth between one system and the next, they might get one small raise and they're not eligible for the Oregon Health Plan, and they've got to go get covered through the marketplace or through an employer, or a loss of income puts them right back in the Oregon Health Plan. And so we're trying to figure out ways to minimize the disruption that those small income changes might have. And some more comments of folks here that really just kind of highlight the challenges that consumers face in figuring out what they're eligible for, where they should be getting care, that we really want to try to address. The next slide. Some of the challenges that we're thinking about, and I think as sort of building on a theme that Jeremy talked about, the waiver is not our only tool. It is not the only vessel that we're looking at to achieve system-wide reforms. And so some of these will be addressed by the waiver, and some of them we just want to make sure that we're considering as we put this all together. But As I mentioned, people are moving from Oregon Health Plan to marketplace coverage and back and forth. Many people, most of the people who don't have health coverage in Oregon, we think are eligible for either the Oregon Health Plan or for subsidies on the marketplace, but they're not enrolled. So we want to reach them and figure out why. Some people have been left out historically due to their immigration status, and there's certainly efforts beyond the waiver to address that. The Cover All Kids program more recently tried to make sure that all kids in Oregon were eligible for something, and there's currently work in the legislature right now to expand that to more adults, and we'll talk about that a little bit more. In general, people who are most vulnerable may be more likely to fall through the cracks, and we want to make sure to get those people. And really, people who have coverage, be it employer-sponsored coverage or coverage on the marketplace, still struggle with affordability. And we want to consider that as part of all of these reforms and making sure that people can afford the coverage they have and afford to use the coverage they have when they need healthcare services. Next slide. Again, as Jeremy alluded to a few times, in really centering equity as we look at this waiver and build it, we have achieved great coverage gains in Oregon in the wake of the Affordable Care Act, Medicaid expansion. Jeremy just mentioned 200,000 more have come on to OHP in the pandemic. But we know those coverage gains are not evenly shared, and in particular, communities of color still face more barriers to coverage, face higher rates of uninsurance, and that is certainly a big target of the coverage and eligibility work that's going to be part of this waiver, to make sure that as we have gains in coverage, that those gains are widely felt, and in particular, historically disadvantaged communities are getting coverage and getting the services they need. Next slide. So to that end, I think our goals on the one hand are kind of simple, is when people get on OHP, they stay on OHP for as long as they're eligible, and people have an easier time getting on OHP in the first place. And I think if we do those two things and do them well, that will go a long way to eliminating the inequities of health coverage. But also there could be other strategies that are beyond those two big buckets that also target eliminating the inequities in coverage, and that is certainly a separate goal. Next slide. So as was mentioned, the waiver is just one piece of the puzzle, but it's potentially a really important piece of the puzzle. Waivers can add eligibility categories. They can help make it easier for folks to get coverage and really expand enrollment and access to coverage for folks who haven't been eligible in the past. But it's important to consider and recognize the other happenings at the state, and the waiver certainly has to sort of conform and fit with those and take advantage of them when possible. So 2019, there was a bill to examine the potential for a public option, and there's currently a bill in the legislature to continue looking into this idea. There's a couple bills that have been referred to as the Cover All People bills that really tried to build on the success of the Cover All Kids program and expand OHP in particular to immigrant communities who have been excluded from OHP because of their immigration status. There is the task force created by Senate Bill 770, the Task Force on Universal Access, that is also looking at potential coverage reforms and a way to get more people in. And there's always other smaller, more targeted efforts to target specific populations or make sure that folks get coverage when they're eligible. Next slide. So with all of that set up, to talk a little bit about some of the broad strategies that we're trying to consider and pursue in this endeavor. And the first couple are really around making it easier to get and then stay enrolled in the Oregon Health Plan. Making it easier to show income, to self-attest to income, and then have the state verify that on the back end so people don't have to jump through as many hoops when they're trying to get enrolled to show that they're eligible. 5-year continuous coverage for kids, so that, especially for young kids, so that when someone gets enrolled, in Medicaid when they're 1 or after they're born, that kid is able to stay enrolled in OHP for 5 years, so that family doesn't have to worry about jumping through those re-enrollment hoops. They can just focus on getting their kids coverage and services when they need it. Considering other ways to keep families covered together, even as income fluctuates. The ACA did a great job of expanding access to coverage, but still you have families who the kids might be eligible for OHP and the parents are eligible for coverage through the marketplace. And we really want to look at how we can think about ways to get that family all enrolled in the same place so that they know exactly where to get care as they need it. And then building on the cover all people strategies, expanding coverage for low-income Oregonians who are not eligible for OHP, be it because of immigration status, trying to take advantage and maximize federal funds for those folks, in addition to any state resources that come with the Cover All People program. And this is an area where we may have to get pretty creative to figure out how to take advantage of federal funding streams that haven't historically been set up to help those immigrant communities. Next slide. And so with this, I want to make sure we have time for maybe some more clarifying questions and making sure that anything that I said was clear. And then after this, we also have a couple prompts to sort of get folks thinking about what they heard and give us some feedback on what they think is fruitful. So is there anything I should say better?
Thank you, Tim. We don't have any questions coming in yet. I have unmuted George. If you'd like to bring your question from earlier when we had a difficult time getting you unmuted, you're available now.
Okay, a question that I want to add two, actually. One is, with this Medicaid waiver, Kids-Hopper wants to put that waiver of 1332 in. Is that going to be applied to this 1115 to help or hurt the medical transports for CCOs?
Well, and Jeremy may also have thoughts, but I can at least start. I guess to start with, we wouldn't want to do anything to hurt that. I think there is, as sort of we allude to, there's different paths forward on some of these ideas, and 1332 waivers are, created by the ACA, really focused on the marketplace side, the private market side, and there are some areas where 1332s and 1115 waivers can overlap. I think we're still waiting for the current administration, the new administration, to provide some more guidance and thoughts on how they see 1332 waivers progressing, what their priorities are going to be, and especially with the intersection of 1115 and 1332 waivers. Historically, they have been kept pretty separate at the federal level. There may be some potential to merge them in new ways, but we're really still sort of waiting on that guidance. So there could be conversations about that over the time, but it's not. We don't want to limit what we're doing on the 1115 waiver side, waiting for more information from the federal government on 1332s. But certainly as we build out these ideas, there might be some areas where we have to make some notes, like, okay, we might need to do something on a 1332 side later on. But with the specifics of Governor Kitzhaber's ideas, I'm not sure that I know quite enough on them to talk about how they might feed into this 1115 waiver.
So it's not going to overload like TransLink down here in Southern Oregon, correct?
I sure hope not.
Okay.
Okay, we have one more question in the chat. Should the agency responsible for qualifying an individual for a waivered service work with OHP eligibility in getting an individual connected to OHP? Lori, I'm not sure if you're still on the phone or if that would be a good question for you. And if we don't have a response for you today, we will follow up on no later than next Friday, June 4th.
Yeah, I'm not sure I'm the best one to answer that, but can certainly help help dig something up.
Good. So we have Rick Blackwell from Pacific Source. The question is, has the agency's thinking of churn changed in light of the enhanced advanced premium tax credits in ARPA?
Well, Rick, that's a great question, and I think that there's a lot of uncertainty as to how, because those increases in the tax credit value are at the moment temporary, how to think about the impact that that will have in the long run, and frankly, to think about how those additional federal resources might be taken advantage of in different ways. And so I guess I don't really have a great answer for you yet, other than that's absolutely on our radar, and we're trying to think about how those new resources either how we can best take advantage of them, and what that means for the churn focused solutions that we come up with. And I wonder if we could go to the next slide too, if we want to prompt any more thoughts on some of the questions. A couple of the items, the thoughts that we've had that we think would be great to get feedback on is sort of like, what else is standing in the way of us getting to these goals of people staying covered when they get OHP, making it easier to enroll, eliminating inequities in coverage. What's standing in the way of these goals, and what other ideas would help the most to achieve these goals?
Timothy, hi, this is George.
Okay, 2 hands raised. Just 1 second. Go ahead.
Okay, sorry. Timothy, one of the goals I would like to have seen is there's been a lot of complaints that a lot of people, the reason why that they're not qualified is because of the income limits. That income limit, I think, if that was taken away, more people could be qualified for OHP or the marketplace. And I think that would at least follow into CCOs for them to take in to really actually help our guardians. It's just the income limit that's really really putting people with the thumb on them, not being able to qualify.
Okay, thank you for that feedback, and I think that kind of feeds in really well with how we're thinking about trying to maintain OHP coverage even as income fluctuates a little bit, especially, but then also keeping families together when we can. And so I think that's great feedback.
So Tim, some other information from the chat around whether there's a path for allowing recently separated spouses to remain on OHP until custody is determined. A question from Kenneth Lewis on, are there discussions around how to expand the availability of OHP to incarcerated people who lose service even for short periods of incarceration and often need significant health care and behavioral health services?
So to take those two somewhat together, on the first one, I haven't been part of conversations on that specific of a topic, but it's certainly something to flag, and we can keep thinking about it and look into that more. On the connection for incarcerated individuals, I'm going to punt that to later in the presentation, because I know that is certainly a issue that we're looking at, but that's more encompassed in one of the next buckets of waiver work. And so I think that they would be better able to address that and the nuance of that issue.
Okay, so some more comments from the chat. From Romy Carver, I think more flexibility for folks with seasonal work, temporary jobs, et cetera, and maybe expediting recertification.
That's great feedback. And on the seasonal work, I think that's really good. And one of the things that has been kicked around is thinking about how to whether there's a different time frame for income that we should look at, and making sure, I think to that point of seasonal work, that if somebody has higher income in one month but not another month, how can we look at those two together? How can we look at a larger stretch of time to make sure we're more accurately getting a picture of a person's income in figuring out how they're eligible?
Okay, along those lines, a comment from Malia Waldrop. I think a barrier for continuity of care is the complicated nature of the paperwork process or online process to reapply. It should be simplified to maintain OHP coverage.
And that, I think, related to the other one too, that's absolutely the type of work we want to look at in here, is how can we make sure that people are not losing OHP because it's complicated to stay enrolled, and passive re-enrollment, and just more ways to keep people enrolled without them having to sort of reprove everything that we already know. So thank you for that.
An additional question, is there a way for those who are in the churn area due to income, purchase the OHP plan as an intermediary step to moving to ACA coverage?
So I think that is an idea that has certainly been out there, and I think the phrasing I've heard it referred to as a Medicaid buy-in, and the challenge with that is certainly something that's on the radar to look into. The challenge is making sure we'd still be able to get some federal dollars, say the federal dollars that would go to those marketplace subsidies, so that those individuals in that situation wouldn't have to, pay the full cost of OHP out of pocket. So I think that whether it's them staying on their CCO or ensuring that they have a really warm handoff enrollment into a plan that's on the marketplace, but that's certainly part of what we're talking about with the churn, and trying to make sure that when somebody loses income eligibility for OHP, they are not just turned out there and said, good luck, go find something, but that we figure out how to keep them enrolled in something, and hopefully something that is, as good as OHP, but making sure that process is a lot smoother. So thank you.
Okay, some other barriers that were raised in the chat: language literacy and technology literacy, transportation, and time to get someone in person who can assist. What would help the most is community-wide literacy classes. Some other feedback: when we have undocumented clients that are older than 65, they are having to wait for a call back from ODHS to see if they qualify for other services. Their application is pending until they have an appointment. These specific clients do not qualify for other services because of their status. So, and other barriers. Some other themes related to accessing mail for houseless individuals and email not being accessible due to broadband. Some outreach, suggestion about outreach via traditional health workers, partnering to contact folks who are about to fall off or who do not have coverage. Some suggestions around needing to have more flexibility for walk-ins because many offices are closed. And difficulty with paperwork and navigating. So a question from John Santa, how much churn is there related to change in eligibility of low-income Medicare and disabled folks for Medicaid dual eligibility? Are there opportunities to provide continuous coverage there?
Thanks for that question. I think we'll have to get back to you on that, Dr. Santa. I don't have the dual eligible churn data handy, but I think that that's something we can try to look into.
So next question from Cassandra Rami. Is there any talk surrounding opening up eligibility or expanding it into a tiered pay system for those who are in the churn percentages?
I think that that is certainly part of that conversation for how to deal with the churn issue and how to take advantage of the marketplace and the federal resources that are supposed to be there to help make sure premiums are still affordable, and how to sort of blend that so that there's not this steep cliff. And I think this is to Rick Blackwell's question earlier. The recovery program, the recovery plan passed at the federal level includes some pretty significant new funding for those premium tax credits that should help more people qualify for zero or extremely low premium plans. And this hopefully will give the states some better opportunity to then connect folks who are leaving OHP to affordable, high quality coverage on the marketplace. But also, I think, as we sort of have tried to allude to, we also want to figure out ways to keep people on OHP when that makes the most sense. If we think, folks are going to just come right back to OHP in 6 months, let's try to keep them there in the first place, especially if their kids are on OHP. And so all of this, I think, is exactly what we want to better explore and figure out how we can look at some creative ways to streamline that coverage transition from OHP to private coverage, but also keep people in OHP if that would make the most sense for their situation.
Okay, looks like we've got one last comment from Julie Christensen. Moving to another CCO area causes difficulty accessing services. There is a lengthy and complex process. Okay, so I'll give another few seconds for some extra questions to roll in. But in the meantime, thank you, Tim, very much. We will still continue to take questions throughout the day, and you can always send follow-ups to the email inbox that is at the bottom of the slide. I think we will go ahead and move into our next section. So this will be the equity-centered system of health. And John Collins will be our presenter. John, let me make sure that you are unmuted. You should be good to go.
Great. Can you hear me, Megan?
Yes, I can.
All right, great. Hi, everyone. My name is John Collins. I'm the Deputy Director for the Health Systems Division at OHA. That's the area that basically runs the Medicaid program as well as behavioral health. Appreciate everybody turning out. I'm looking forward to going through this particular concept area and hearing what kind of feedback folks have. One thing I want to note is before I head into the details of equity-centered system of health is basically that you'll end up hearing a lot of overlap, I think, between the different concepts as we progress. There are pieces that Tim just presented that you might hear a little bit of or echoes of in my presentation, as well as the remaining presentations. And this is part of our organization process that Jeremy outlined earlier as we're kind of previewing these concepts and getting feedback from folks and ultimately landing on an organization that we want to present back to CMS. So just wanted to give folks a heads up on that. So similar to Tim's presentation, we're starting off all of these concepts with reflecting back on information that we've heard from the community, whether it's individuals who've received services or who've contributed to various planning processes that we've engaged in, providers, CCOs, et cetera. And one of the things that we've clearly heard is that the racism in our system prevents folks from being healthy. And what we're talking about here in a lot of ways is that there are things that are inherent in our Medicaid system in this case that basically prevent people from accessing services appropriately or accessing the kinds of services that would be best for them in their particular situation. You know, there are a few comments that we have here that are illustrative of that. And I think, although it was obviously super unfortunate that we had to go through a world pandemic, but that really highlighted and illustrated a lot of what we already understood to be racism in our system. I mean, we had issues where the communities weren't necessarily involved in how addressing how COVID was impacting them personally. There were issues around how vaccines were distributed. It really highlighted the direction that we were already going as an agency to work towards the elimination of health inequities. And so this opportunity under our waiver that we're looking to apply allows us to really dig into some of the systems that are inherent to the Medicaid system and looking for ways to change those and work with CMS, work with you guys, the community, stakeholders, tribes, et cetera, to find ways to make changes to those so that we can eliminate those barriers and ultimately move towards our OHA goal of elimination of health inequities. Next slide, please. So, what is an equity-centered system of health? Normally, in past waivers, we've put in language associated with a person-centered system of health, where we're looking to make sure that individuals are able to basically choose their pathway towards healthcare and getting the kinds of services that we wanted to achieve. And that's still really important. But what we're recognizing, and what I was alluding to in the previous slide, is that there are certain barriers in terms of how our system is constructed that prevent that from happening. So the idea behind equity-centered system of health is that we're looking to provide a health system, an environment where people can basically achieve their full health potential and well-being, and they're not disadvantaged by their race, ethnicity, language, et cetera, all the things that are in our health equity definition. And it basically is going to require these three things that are bulleted here: an equitable distribution or redistribution of resources and power, recognizing, reconciling, and rectifying historical and contemporary injustices, and a waiver from CMS and some of the institutional rules that basically support the racist system as it currently exists. And that's what we're really going to have to dig into. Not all of this work that we're trying to do around the elimination of health inequities requires a waiver. Much of it is ongoing right now as we speak, and can still happen, but we will need to work with CMS to create certain changes that we really need to have happen in order to ultimately achieve our goal. Next slide, please. So I think this set of bullets really kind of it highlights some of the things that we have to do in order to make this happen. We have to work with communities of color in Oregon and cannot simply work to look at the broad population and accept feedback. We have to seek out and make sure that we are working with all of the individual populations within Oregon to make sure that we're getting the feedback that we need from them, and that it's not hidden under a broader cloak of the broad population. We have to address the needs that are resulting from the inequities. And that's what we're trying to do specifically with some of the waiver request and authority that we're looking for from CMS. We have to really take into account and do a better job of taking into account lived experiences of folks who are on Medicaid or have been on Medicaid in the past, and listen to those experiences and try to utilize them to improve the system. We have to ultimately change the health plan to help members with complex needs that are stemming from the systemic racism. Some of the strategies that I'll outline a little bit later basically note and acknowledge the fact that some of the barriers that are sometimes the care, the kind of help that people need is there, but they can't get it because of some of the rules that we're currently operating under. So we have to identify those and look for ways to eliminate them. Next slide. So our goal is for OHP members to experience coordinated and integrated care across health and social systems. That's pretty much always been our goal, but we're understanding now that we need to go about achieving that goal differently than we have in the past. And again, as I noted earlier, not just looking at the broad population, but thinking about the components of the population and making sure that everybody is getting to that goal that we're wanting to achieve. We want to make sure that there are no language, cultural, or economic barriers to care, and that ultimately OHP enrollment's preserved as patients transition between those different systems. So next slide. I want to be clear that the current waiver that we're under, and that will, as Jeremy mentioned earlier, we will ultimately end up renegotiating the waiver that we have now and then add additional aspects to it. But the current waiver that we have right now has a lot of mechanisms that allow us to address health inequities and achieve the health equity that we're looking to demonstrate for the system, and have that goal of equity-centered system of health. Care coordination itself delivered through the CCOs, and that includes intensive care coordination. It's supposed to provide a holistic way of approaching an individual's care that takes the whole array of issues that might be impacting a person's health and being able to address them. There are barriers that we have still that we need to address to fully actualize that particular idea. We tend to rely on evidence-based benefits. In fact, our whole structure is based off of a list, being able to provide services for a list of various diagnoses, clinical diagnoses that help us, that we know that there are services that are evidence-based to address. That's great, and that's something we have under our current waiver, but we need to also acknowledge that in some cases, some of the issues that people face and that are impacting their health are not necessarily clinically based. They're based on social determinants that the individual might be adversely experiencing, and we need to look for ways for OHP to be able to pay for that. And then finally, up here, in terms of a scope of a current waiver, we are able to utilize some services for individuals that are outside of traditional benefits. And a lot of that's focused on tribal care as an example. We need to be able to broaden that out a little bit more so that we can involve more people, more types of services in people's care, so that there actually can be reimbursed through Medicaid and seem more appropriate, culturally appropriate in a lot of cases for what the individual's needs are. Next slide, please. So the next set of slides that I'm going to go through all kind of at a very high level address some of the strategies that we have. And I will just be going over these at pretty much a high level. There are many sub-strategies that are on the table right now underneath each one of these, and I might bring up a couple of them here and there, but we don't necessarily have time to cover everything that's on the table. And actually, we're still looking for feedback from the community, which is why we're having this kind of engagement with you guys. So one of the first broad strategies is better serving populations and transitions between settings. This was actually something that was brought up in the previous presentation that Tim was doing that he punted. This includes the idea of looking for improved and consistent coverage for people who might go into federal or state prisons, or as individuals who are in those institutions are being released. For example, maybe enrolling them 30, 60 days prior to their release date, so they can become engaged with maybe a care coordination or a CCO, and actually be ready to receive services the day they leave prison. A similar situation exists for individuals who might be involved with local law enforcement and maybe are in local county jails, in some cases waiting for adjudication on a service. Right now, a lot of those individuals cannot receive Medicaid services because of the rules that we have to operate under, but we're looking to write up language and talk through this with CMS so that those individuals could receive Medicaid reimbursement, and some of the nuances of the rules wouldn't necessarily get in the way of the individual receiving those services. This is true also within the juvenile system. It's also a big issue for folks who are who have been admitted into the Oregon State Hospital. The Oregon State Hospital is what's known as an IMD, and it's a large institution that focuses solely on mental illness and the treatment of mental illness. And because of that, we have rules against being able to utilize Medicaid dollars for individuals who are there. There are ways that we can work with CMS, potentially get waivers to that, maybe on the front end or the back end or both, of people going into the state hospital, similar to the situation that I talked about for folks who might be in federal or state prisons. Next slide. Another big issue that has an impact on equity-centered systems is housing and social needs. A lot of times individuals are treated based off of their clinical needs as opposed to what might be more of a social situation that they're in that has a definite impact on their health. So what we're looking to do is work with CMS to really highlight that as an issue and figure out ways to address it utilizing our Medicaid system, so that, for example, if a person is in a crisis situation and we're looking to help alleviate that, being able to take into account the immediate problems for that individual that might not necessarily be clinically based or medically based, and then be able to direct that person and get that person into services that would be helpful, like maybe a temporary housing situation or maybe even something more permanent, would be a huge boost for our system and the ability to take care of folks. That definitely has an impact on the person's health and their health outcomes, but is not based off of clinical symptoms or needs that the individual and that our system typically looks to try and address. This requires a waiver from CMS and is something that we're hoping to really work closely with them on. Next slide. Behavioral health access. None of the concept papers that we're working on focus solely on behavioral health, but I think as you become familiar with the ideas that are being presented, including within this section around equity-centered systems of health, you can see that there's applicability to one of the bigger issues that we face within our healthcare system, which is around capacity and access to services. We're working with the legislature as we speak here to basically improve funding issues and address a lot of this through bills. The governor proposed a number of different policy option packages that address behavioral health, and we're going to continue to work those, but there are changes to the Medicaid system that could also facilitate and actually allow those investments that the state is looking to make them more effective and efficient. One of the big issues that we might be able to hopefully address is how we utilize peers and recovery services for individuals who might be experiencing mental illness or substance use issues. Right now, it's very difficult to have those types of services paid for through Medicaid, but we are exploring options and concepts that we want to try and work with CMS on to change some of that. Other kinds of things that we're looking at, as an example, is we're looking to be able to fund how Medicaid currently perceives children. Right now, that's technically related to their age, and it goes from birth to, if I remember right, it's either 18 or 21, depending on the situation. We're looking to maybe expand that to age 25, which in a lot of ways is more developmentally appropriate in terms of people's brain development and structure, but it's also more appropriate in terms of some of the services that individuals need within that age range. And right now, there are some artificial cutoffs that basically eliminate certain services from individuals when they change from, say, 19 to 20. And that's pretty arbitrary in most cases. Another thing that we're looking to do, and again, this is through investments with state dollars, but also working with CMS, is by expanding the number of providers and the types of workforce, people that are available within the workforce to help address services. Some of this can be done through the utilization of community-based organizations and peers, as I mentioned, but there might be other options that could be put on the table as well. Next slide. And finally, there are some tribal specific strategies that we're working on with the tribes. We work directly with the tribes in a government to government type relationship. But many of the rules that are associated with Medicaid that help access services or dictate the kinds of services that can be reimbursed through Medicaid are set up through, again, CMS. And there are many opportunities that we have to be able to potentially address some of those, such as utilization of tribal-based practices, getting a higher match in some cases for services that are being delivered by tribal organizations. Again, some of the same issues that we've talked about in some of the prior strategies, such as better use of and payment around services that might be directly impact social determinants. So there are a number of different opportunities that we have to address things there. Next slide. So just kind of in summary, we're looking at impacting transitions, housing and social needs, behavioral health access, tribal services. And to kind of take this back to the concept of an equity-centered system of health, I just want to kind of quickly go through each of those again and talk about how the system is impacted and how it should lower the health inequities that we're currently experiencing within the system. So as a quick example under transitions, if OHP and CCO enrollment is impacted, that creates barriers to services. So, and this often has impacted, according to our data, disproportionately people of different races and ethnicity other than white. The elimination of this impact can create a better system for access and coordination of services. With housing and social needs, as I kind of went on with a couple of the strategies, we're usually looking at, while we usually look at diagnostic criteria, that are medical in nature. If we switch to social needs that dictate provision of services, we can better address those particular issues for individuals, which are, again, often impacting communities of color, tribes, other non-dominant populations within the Oregon broader population. Behavioral health access. We want to be able to access services that are outside of a typical medical model and utilize peers and community-based organizations to do this and increase the workforce, which just in doing that can create better access to services. This could help the services become more in tune with what individual needs are and be more culturally appropriate for individuals. And finally, with the tribal specific strategies, again, what we're talking about here is, as in with many of the other categories, is eliminating barriers to access and to services that are appropriate to particular populations. And many times the rules that we have within Medicaid basically create barriers to that and or barriers to being able to even be enrolled within Medicaid. So that was a lot of me talking. If we go to the next slide, we have the opportunity for you guys to ask questions, similar to what we did in the previous concept. You can ask questions about some of the information that I went over, and then the next slide we can switch to is a couple of prompts that I have for y'all to get some questions from.
Thanks, John. Some questions from the chat and comments. So the first question from Heather McClellan: as we increase and encourage culturally specific providers to join the network, how do we change the Oregon administrative rules or auditing to make sure we are enforcing those rules in a way that respects the requests we have for culturally specific care?
Yeah, that's a great question. And as we've mentioned throughout this so far, there are things that we work with the CMS to get the rules changed, and then there are things that we would do internally to the state. If we're able to work with CMS to broaden out the eligibility requirements or service requirements that allow services that, for example, now aren't currently allowed under Medicaid, it would be incumbent on us to also go back and look at our administrative rules around the provision of services and possibly make changes so that they're in alignment with our broader policy goals.
Some feedback from Charmaine Kinney. I know that providers have to collect language from, I think they mean the health authority has to collect language from providers, but these are not useful the way they are collected. The providers who say they know a language often do not know that language at a level they could adequately provide care. Getting directions or ordering a coffee in a different language is very different than interpreting different dialects and having a real understanding. The collection of this data has to include the level that a person knows that language. If they are not fully bilingual or bicultural, they should not be providing services in that language and should be required to obtain translation services.
Yeah, thanks for that feedback. I think what that's noting is some of our, quite honestly, failures so far, and implementing some of the changes that we need to make in order to make sure that services are appropriate, that language is being, how services are being communicated to different populations or people who might not use English as their primary language. Some of that might be addressed again through some waiver activities, but I think honestly a lot of that can be addressed actually within some of our state rules and how we enforce those. But that's great feedback.
Some additional comments. Many smaller clinics refuse to take the Oregon Health Plan because of bureaucracy and the bureaucracy being too overwhelming. Some suggestions to improve the customer experience to improve enrollment. Additionally, we've got an observation that many evidence-based benefits do not serve BIPOC populations.
That's true, and again, it's it's kind of building off of one of the various themes that kind of hopefully came across as I was presenting some of this information, is that a lot of what's reimbursed right now through Medicaid is based off of a very medicalized model, and some of the services that we need to be able to deliver do not fit within that model, which is typically what an evidence-based practice follows. So yeah, I'm in agreement with you there, and we are looking for solutions to that.
Okay, we've got reinforce the idea that having a designated tribal liaison for each of the CCOs that we can deal directly with to coordinate referrals and transitions would really relieve some of the issues that we're currently seeing.
That's great.
Let's see here. Just a comment from the Oregon Nurse Association. Deborah Riddick appreciates the equity-centered focus. An invitation from Allie Linfoot, Peer Services Coordinator and Program Planner for Clackamas County Behavioral Health Division. A peer-delivered services system of care that has been operating successfully for nearly 10 years and provides peer support services to over 7,000 people annually is located in Clackamas County. The county uses Medicaid funding to operate the system. There is an open invitation to OHA to tour the system. This was scheduled for April 2020, but obviously the pandemic prevented that from happening.
Thanks, Allie. I'm sure we will get that rescheduled, and we'll look forward to your feedback and helping with a waiver.
And then I think our last question that we have so far, does the state have a pool of interpreters that are willing to bill OHP for non-CCO members?
No, we don't. But I will say that is something that's needed and has been brought to our attention from many folks. And it's not something that I'm directly involved with, but I do know that there is work in progress to try and address that in somewhat ways that are similar to the way ODHS has tried to address it as well.
Okay, my comments. Unfortunately, the folks who really need the help do not know where to start finding it or have problems trusting entities in place. Having diverse workforce may help to provide more trusting and relatable connections between services and people.
I agree, and I think I mentioned several times throughout my part of the presentation concept of community-based organizations, and this is something that's really been highlighted again for us through some of our COVID work, but more recently we've been working on. There was a ballot measure passed referred to as 110, which is supposed to increase the access to services to substance use services in particular, and decrease the participation and interaction with law enforcement around drug and alcohol issues. And it's really focused on the utilization of community-based organization and non-traditional service providers. And again, to the degree that we can work that within to the Medicaid system, hopefully that can allay some of those kinds of concerns that were brought up by that comment, so that it's not access to services and access to Medicaid in general is not reliant on an individual having to encounter a bad situation where all of a sudden they need services and don't know where to turn, but maybe could be seen as more of a social benefit for individuals that they can become aware of much earlier and then utilize as appropriate.
Okay, I think our last question before we move into the next part of our agenda from George. You have a hand raised. You are unmuted. Please feel free to ask your question.
Okay, question I want to ask is, with this waiver that has to be done, is it going to, how is it going to help the brand new CCO 3.0 that will be coming up after the next 5 years?
That's a great question, and I'll just give a quick answer to it, and Jeremy or Lori might want to jump in there to maybe even give a more full answer. But well, in a lot of ways, I mean, this helps us set the rules in which we will be operating under. And there are lots of details within the next round of CCO contracts 3.0, as you refer to it. I think we're going to come up with some other name besides 3.0, but there are things that will build a foundation for with the waiver itself. And then from that, there are all sorts of details that go into that actual contract. And just like the previous contract, there will be a very large and extensive process for getting community feedback in terms of what that might look like. But what we're looking to do here is set the rules for how those CCOs, basically the parameters within which those CCOs can operate, and then the contracts can have all sorts of details within those rules. I don't know, Jeremy or Lori, if you want to expand on that at all.
Yeah, the timing of the waiver kind of comes halfway in the middle of our 5-year contracts with CCOs. So it's a mix of, I think, the final implementation of CCO 2.0. And there's certainly, as I talked about, we're using feedback that we received through the CCO 2.0 process. And the waiver will help us, move those goals forward. And secondly, it will bridge into the next contract. So certainly we'll begin to set the framework for things for the next contract period after this one.
Great. So thank you, everyone. Thank you, John, for your presentation. We've got a scheduled break for the next few minutes, so we will return at 2:25, so in about 7 minutes. Please continue to add questions to the chat. Anything that we don't address today, we will post by next Friday. So let's take a quick break and we will see you all back in just a few minutes. Let's go ahead and get started with our next section. So next up, we have Chelsea Guest to do our policy deep dive on encouraging smart, flexible spending. Chelsea, you should be unmuted and you are good to go.
Great. Can you hear me okay?
Yes, we can.
Great. Well, thank you guys for coming back from our short break and talking about finances. As Megan said, I'm Chelsea Guest. I'm the director of the Office of Actuarial and Financial Analytics in OHA. This next focus area is about aligning financial incentives to encourage smart and flexible spending in the CCO model. Jeremy mentioned it at the beginning, but just as a reminder, CCO stands for Coordinated Care Organization, and they serve the majority of the Oregon Health Plan members. So first, let's start with the input we've received related to finances and investment. What we've heard from community is that CCOs need flexibility in their budget to fund and invest in basic social needs of their members, such as access to healthy food and housing. And also that the community voice is critical to targeting these investments, and the community needs to be part of that decision making. Next slide. We've also heard a significant concern about housing stemming from those social needs. In a recent CCO stakeholder survey, about 70% of people ranked housing as one of the top 3 areas that should be addressed. Helping people navigate housing services and affordable housing is a key area of need and investment to improve health outcomes. This is further supports the need for flexible spending and aligning incentives to meet members' needs. And is really a cornerstone of the well-being for community, especially communities of color. Next slide. So now thinking about the waiver and addressing some of the challenges and putting this input into action, we've been exploring options to kind of build off of our successes, but also trying to create strategies that increase or enhance flexibility in the way services are provided, similar to things that we've already discussed in previous sections. We want to encourage CCOs and align incentives to really go beyond the medical system and truly pay for things that keep people healthy and keep it at a sustainable rate. So building on that flexibility and pushing things forward. Next. Oh, and just real quickly, in terms of like different and variety of different stakeholders, One of the big social determinants of health items related to health inequities is that inequities are even more, have problems with designing frameworks and building investments. Some of the things are just the lack of data or the lack of services provided. So building off of our current system may have some tricky pieces when it comes to financials. Next slide. Our two main goals in this area, which really support the variety of goals that have already been discussed, is really shifting power for community investments to the community itself, and trying to work on that. You'll hear some more about how we're engaging in the community, and also how to make sure that the care and supports are there for people to stay healthy. Next slide. So what successes have we done, or what was the intention of the global budget, as we call it, or the funding source for CCOs back in 2012? The intention was really to combine funding into one budget that covered physical, behavioral, and dental services, and we did that. Previously, these services were handled by separate contractors, and other goals were to tie significant portions of the global budget to quality. We encourage CCOs to provide flexible services to address non-medical needs and also keep spending sustainable. And that's a really key part of this portion, and we'll build into the next section that Krista Mars will talk about. In 2012, we committed to CMS that we would keep things sustainable at a rate of growth in the Medicaid budget. In exchange, we got federal reinvestment for $1.9 billion for the initial waiver. This was definitely key in the negotiation, and we want to build on that. The 2012 vision was simple, sustainable, and flexible. And it's important to move forward on that and keep that for our future waiver renewal. But we also want to enhance the framework with added flexibility, accountability, and a stronger community voice from the input that we've received. Next slide. So this is just some grounding on terminology and things that we commonly use when we're talking about budgets or how the CCOs are paid. So the term global budget is meant to describe the funding given to a CCO in total for integrated service delivery across physical, behavioral, and dental services. That includes also health-related services that improve health. CCOs receive this money each month, and it's built depending on their region, where they operate in the state, maybe different characteristics, more rural versus urban, and also the members that they serve, kind of characteristics they have. And that leads into capitation rates. Another term we use in Medicaid is capitation rates, but it is often thought of as a premium in commercial health insurance. So that might be something that you hear commonly. Capitation rates are payments OHA determines for each person on the Oregon Health Plan that is paid monthly to CCOs. And it varies depending on the characteristics of the member. So for example, a child is assigned a very different rate than an adult, as their care needs are different and generally differently. The combination of capitation rate and their members enrolled in a CCO results in a tailored global budget that's sent to the CCO each month, and that becomes the funding source to support services for CCOs. And how that is built has changed and evolved over time, but we want to make sure that that in total is sustainable into the next waiver. So the next slide. So while we have made successes in terms of integrating this funding stream and moving forward with a sustainable rate of growth, there are still many challenges that remain. One key challenge is that financial incentives for the CCOs is not necessarily aligned perfectly with eliminating health inequities. And also promoting long-term upstream investments doesn't necessarily connect in the same way. Incentivizing and creating accountability to the community and health equity is really key, and we've heard that loud and clear. In addition, in many CCOs, the power and decision-making on these community investments is at the CCO level versus with the community that they serve. We want to improve that. We also know and see the inefficiencies and waste in the system, and they're persisting. We have made some big strides in terms of quality outcomes and in reducing unnecessary ER visits, things like that, through the Quality Pool program. But there is a delicate balance of how much waste and promoting efficiency we do while protecting members. So we need to balance that. These challenges kind of started us down the path of looking at strategies that we are now exploring. So next slide. As part of this waiver renewal, we want to build off of our successes, as I mentioned, in terms of sustainable rate of growth, and continue to address the many things we hear from the community. The strategies we are exploring include flexible and sustainable global budgets, increasing accountability, and shifting the power to community. Okay, next slide. So this one, let's unpack it a little bit. So our first strategy is really to recommit to that sustainable rate of growth. This is consistent with our last two waivers. The last waiver didn't have a reinvestment piece to it, but we did commit to the sustainable rate of growth. We want to also set the expectation with CCOs to invest upstream as part of this sustainability. And then we want really to give them a predictability year to year. So CCOs can invest more in preventative and upstream investments. That flexibility on the ground and that their ability to really see that ROI in the end is really how we're trying to align the financial incentives here. So the next slide. So while increasing budget flexibility and having the sustainable rate of growth target are intended to really shift resources to better meet members and community needs, the combination doesn't necessarily ensure that CCOs will use that flexibility to best serve members and communities. So Oregon plans on also putting part of the strategy some accountability and enhanced accountability, some of the things that we are already doing, but enhancing them forward and really shifting to focus on target health inequities and moving that needle. Oregon strategies just on the slide are really about strengthening quality metrics program that incentivize health equity and ensure access and quality, reinforce CCO's responsibility to provide core benefits, really more accountability related to that, and creating more feedback mechanisms that might include providers, advocates, community members, and the CCO's provision of core benefits, and making sure that they're appropriately addressed. We also are looking at streamlining access to pharmacy benefits, particularly those with behavioral health conditions. These are kind of things that we're looking at in terms of balancing both the flexibility for CCOs with some accountability. And then next slide is really about shifting power to the community. We've seen some questions already come in about this, and we're really thinking about a different process when it comes to building this strategy and building it out. So eliminating inequities will require centering that community voice in decision-making and identifying opportunities for community to lead the resource distribution or in cases redistribution to improve the health of priority and underserved communities. We've been engaging with the regional health equity coalitions on kind of a co-created partnership to build a strategy in this area and try to identify some resource opportunities and different strategies that might be more centered with the community voice in mind. So really trying to focus on the process here and trying to build on the community engagement. In terms of all of these wrapped together, they do focus on the funding and financial alignment. A lot of them are building off of successes that we've had over time, but there are a lot of things underneath this. The financial incentive model or financials that CCOs receive need to support the program. And so that includes looking at the different strategies or different presentations you'd already received and how we can support that with funding as well. So I think I went a little quick, but I think that might only give more opportunity for questions that you have. And we really want to hear thoughts here. This first section, and obviously open to any questions or discussion here, but any clarifying questions you have for me and any ideas or additional barriers or challenges or goals that you might have.
Thanks, Jessie. We have a comment in the chat that quality metrics must be aggregated by race and ethnicity in order to move the inequity work.
Thank you for that. We are looking at strengthening the quality pool metrics to center on health equity, and we appreciate that comment.
Okay, I've got a hand raised from George. George, you should be unmuted. Please go ahead, ask your question.
Yeah, with the strategy on shifting the thing for communities, is this going to put a burden or is this going to put pressure on the CACs that are in the CCOs to help with the chip and chaw process? Is this going to put pressure on us in the CACs and including helping the medical transport companies for medical appointments?
So the process is ongoing right now. There has been a bill associated with this work that was proposed in trying to bridge the negotiation with CMS about community-driven investment. I don't know if we can comment right now about how that will fall in terms of the structures that exist, in terms of the chips and the CHAs and all of the acronyms related to that you just mentioned. But I think having the community process that's existing, the strategies will hopefully emerge in both using and leveraging the supports and the processes that have occurred. Did you have any specific concerns related to community investment that you wanted to elaborate on?
Yeah, since it's our responsibility to do the chips and half of the CHA, and we are the front lines of the CCO as a CAC to get feedback and stuff, are we going to be required or put pressure on us to make sure that the CCO does their work when there's matrix being set up, is what I was trying to refer to, when it also includes medical transports, like TransLink down here?
You mean the core benefit portion?
Right.
Of accountability.
Right, because other CCs that are in the CCOs are doing the work for the community, or at least getting the input from the community, since this is being shifted over to the community work.
I think there's always going to be a shared decision-making process between community and kind of the medical healthcare needs that exist in the program and under the CCOs. So having some balance there. In terms of the strategy that has been landed on, I don't think we have that right now, but I do appreciate your comment.
Okay.
Thanks, Chelsea. Some other comments from the chat. Rick Blackwell from Pacific Source. How would the model take into account community governance already taking place in CCO service areas?
Great question. So generally there has been a lot of community involvement in some CCOs, but it's not widespread. And I think that's one of the pieces that we've heard in terms of feedback is how can we make that more the norm and centering the voice of the community in all the CCOs. I do want to cite that there has been some good strides in terms of community decision-making on investments that some CCOs have done, and I think we want to build on those successes.
Okay, another question. Let's see, Marla Davies from Gilliam County Transportation. As I have heard over and over in this presentation, accessibility to services, transportation for the frontier rural clientele, both Medicaid and Medicare clients, inequity in the frontier area need transportation benefits which are available. Accountability can be tracked by the NEMT transportation programs who are now being tasked with providing transport services for free, or many of them simply do not have that option. And I am not sure how this will continue for our county. Thank you for that comment. Yeah. Okay. A comment from Charmaine Kinney. CHIPs do not have decision-making power laying within BIPOC communities, nor do CCOs. Until that is done, it will be from a dominant framework, which will never serve BIPOC communities in a way that will truly reduce disparities. And a question from John Santa. Any thoughts about patient safety? Are we paying for errors or unsafe care? Are errors more common in vulnerable populations? There's mixed evidence nationally around this. Are we paying for errors reported by patients?
I think that's a great question, something that we want to dive into a little bit as part of the strategy in terms of looking at recent healthcare spend a little more from the efficiency or waste perspective. But I think one of the key challenges is balancing that with making sure we're also meeting the basic needs and protecting the member from any access restrictions or things like that that would also be coupled with that. But inefficiencies and things like that are definitely part of what we're looking at right now. Appreciate that comment.
Okay, another question from Sean Colmer. How do you anticipate communicating what is federally permissible as an expense for Medicaid and community conversations?
I think there's a lot of questions related to what is federally allowed for medical spend and evaluation of medical spend. We're both looking at it, I think, from two ways, trying to create some benefit packages that support people in different ways. We talked a little bit about transitions and things like that, but also how we evaluate recent healthcare spend is something we want to look at a little bit closer in terms of efficiencies, but also not reacting as quickly to some of those changes in how the system is interacting, and maybe that will open up some opportunities to invest in different things. There are some open areas that are now that have been used. We call them health-related services or activities of improved healthcare quality. Those activities have been encouraged and promoted currently in our program. And I think having that conversation during this waiver negotiation is part of that as well.
Okay, and I have a hand raised from Elena Rivera. Elena, I've unmuted you. Please feel free to ask your question.
Thank you so much. I work for a early childhood advocacy organization, and we partner a lot with community-based programs. And we've heard that one kind of barrier they face is that they may receive like a kind of short-term grant from a CCO to support their work, whether it's providing parenting education programs or home visiting or doula supports. But that after the short-term grant, you know, the funding might end kind of abruptly, and there isn't like a long-term continuity of support and investment in community programs. And so I'm just wondering if that could be one interesting indicator to track as far as like holding CCOs accountable to investing in their community. Like, what's the longevity of the grants to community-based organizations and programs, given it can sometimes be counter productive towards the outcome of health equity if we're, you know, providing short-term support that isn't sustainable in the long run.
Thank you for that comment. I think longevity of funding is something that's difficult across the whole program, depending on what services are being provided and which kind of entity is receiving that funding. But I think that the sensitivity also of building these programs and having that longevity is very important. Lori, did you want to jump in?
Nope, you're doing great.
Okay. Thank you for that comment. I really appreciate it.
Yeah, so I don't have any additional pending questions. If we want to go to the next slide, I think there are some questions that we could ask the group.
This one is more of a prompting question just to highlight our goals again about community investment in community decisions, and then also making sure that people get the care and supports they need. This goes a little bit to the social needs that was at the beginning with the input slides, but we're really trying to figure out if there's things that you can see that are standing in the way of our goals that we're not identifying, what would help the most, and then also from a sustainable rate of growth perspective, what strategies can slow healthcare costs to achieve our goal of potentially shifting some of that resource to more community investment over time. Very interested in people's thoughts here.
So there's a question in the chat from Dan Cushing. Community investments are not included in CCO's base budget. How do you fix that problem?
In terms of looking at strategies, I think we need to talk more explicitly about that problem and how we discuss it with CMS and looking at flexibilities for how we do that. I think that the idea here is that we're aligning incentives, that these programs and these social need investments or social determinants of health investments will have a payoff in terms of long-term and lower cost of care and drive less acute and waste in the system. So I think the goal is to create that incentive in how we're allowing for flexibility and sustainability. How we earmark or identify specific parts of the system or part of the budget is something that I think is something we'd want feedback on or input on, definitely part of the community decision portion of our strategy and engaging the regional health equity coalitions. Definitely open to input on that in terms of actually creating the incentive for them and for CCOs that's real and important to invest in these things.
Okay, I've got a hand raised from George. George, you are unmuted. Please feel free to ask your question.
Yeah, you were talking about other services outside the CCO, I think it was. Can you clarify what type of services those would be? And if those services were to be present, would they also be applied to transportation?
So I think you might be mentioning when I talked about health-related services, which is something CCOs can invest in right now. It's something that goes towards their evaluation of expenditures when we look at their, reports. Health-related services are really about non-medical services that are improving people's health or improving outcomes. And that could be maybe additional transportation support. Another term that's used is care coordination, which is an important, or case management. That's an important part of what CCOs do in terms of connecting people to support. All of those things, I think, might have been what you're speaking to. In terms of things outside CCOs, more technically, the answer is some things do exist outside the CCOs, including our open card population, some of our services related to mental health residential, and things like that. Did that answer your question?
Yeah, it did. But I also wanted to know, would this waiver also enforce the providers to provide services to people with a disability, like the blind and the deaf, when they go into doctor's offices and such?
This is Lori. I'll add a little bit onto that. The waiver won't force that, and though transportation services are allowed and should be offered to people with disabilities. Some folks with disabilities fall under our 1915 waiver, and can receive a separate set of benefits if depending. So I just want to point that out. But and that's if they're receiving services through the Oregon Department of Health and Human Services. In terms of services that can happen outside the CCO, when we're talking about some of the social needs that were covered by John earlier, an example might be housing supports. So if we do develop and request a suite of housing services, the CCO would pay for it, but those services could be administered or offered by a community-based organization, for example. So, I think we are thinking in different ways where some of these services won't be offered just through the health system, but through community-based organizations, and so that's a difference. There could be a potential to offer additional transportation services. So as you are well aware, there's a federal law that requires Medicaid programs to offer non-emergent medical transportation. In North Carolina, in their waiver, they were allowed for people with certain conditions to offer and to have transportation limitations or a lack of access to transportation to receive non-emergent health-related transportation. So it might not be to a medical doctor, but other visits or other trips they need to make that are related to their health. So that would be an example. We are looking at that. We haven't landed on what the list of social needs are. So that's where we are, and hopefully that's helpful.
Thank you.
So we've got about 1 minute left. A comment or question about whether anything is being done to address the fact that non-pregnant women have no vision coverage. So diabetics receive eye exams on OHP, but no adult, unless they are a pregnant woman, may see an eye doctor or receive a prescription in eyewear.
I'll speak to this one too. That is true in Oregon. We don't have a vision benefit. We've actually been looking at that within our Medicaid program. It costs general fund dollars, so we'll have to make a request to the legislature to allow us, to add those services. And that is work that's underway right now within Medicaid. So we don't need a waiver to offer those services. What we need is general funding through the legislature, and then we can add those services. Hopefully that's helpful.
Great. So thank you, Chelsea. Thank you, Lori, for answering some questions on this section. We are now going to move over into our last deep dive. Just as a reminder, everyone, please feel free to continue adding questions to the chat. Anything that we don't get to today, we will have posted for you by next Friday, responses. So let's go ahead and switch over to Chris DeMars from the Transformation Center. And Chris, let me make sure that you're unmuted. Okay, you should be unmuted now.
I am. Thanks, Megan. So hi, everyone. Chris DeMars with the Transformation Center, as Megan just said, and I'll be talking about the fourth and final waiver strategy, which is to reinvest savings achieved through our health reform efforts back into communities to correct historical inequities. Next slide. So what we've heard that people want investment in the programs that support their health and healthy communities beyond the healthcare system. And that's been a theme I think we've heard through most of the other presentations as well. So examples you see here include prevention, parks, community centers, but the list is long. Next slide. Thank you. So if we're successful at containing costs through our health reform efforts and are able to prove to the federal government that these efforts have actually saved them money, we're hopeful that they would give us some of those dollars back. And we're also hopeful that we'd be allowed to redirect those savings into community level investments that address health inequities, most of which are beyond the scope of the healthcare system. Next slide. So here are our two goals for this stream of work. And as I said, first, the savings that are generated through health reform would be reinvested into communities. The second, and a very essential part of this strategy, is that community leaders would take the lead on and work together in developing strategies to eliminate health inequities in their communities. Next slide. So the source of the savings that I keep referencing would be through successful implementation of Oregon's statewide sustainable healthcare cost growth target, which is a more inclusive and aggressive cap on total Medicaid spending growth. And this would result in substantial savings to the federal government by slowing the rate of cost of growth in healthcare expenditures. So our rationale is that we plan to lay out in our waiver is that this would lead to a marked decrease in federal funds coming into Oregon's health system. And these are dollars that we would have used to provide innovative services and programs to the most vulnerable people living in Oregon. So we want to ask CMS to provide an upfront and ongoing investment of the projected savings to support Oregon's health equity initiatives during our waiver period. Next slide. So one of the promising strategies that we've come up with for these investments is something that we're calling health equity zones. And in a health equity zone, this would comprise of communities who would be the decision makers on investments to support a range of supports and services that they know are highest priority in their areas for their communities. And so some of the examples of investments which could be combined to support community needs include those you see on the slide: a culturally responsive healthcare workforce, outdoor opportunities and green spaces, affordable high quality childcare, and housing related services. And then another promising strategy is investing the savings in statewide equity priorities. So this would entail OHA collaborating with community partners to identify where statewide investments could significantly reduce health inequities on a broader scale. So that was pretty quick. If anyone has any clarifying questions for me about this, this area, feel free to put them in the chat or raise your hand.
No questions so far.
We could even move to the next slide where I have a few prompts too. So as has been the case with the other, oh, do you see something, Megan?
Yeah, we do have one question. How will communities be identified?
That is a great question. That has to be yet to be determined. And I think we would partner with communities and get input through this waiver development process to flesh that out. So if you want to provide some input now, we're all ears. And so while folks are thinking, so this, as you've seen the other three areas, you have the goals on the right-hand side, you know, what's standing in the way of us achieving these goals, what would help the most, and then specific to this, I'm curious to hear what types of community investments might have the most impact.
Okay, so we have one comment. It would make sense to partner with community agencies that have helped people during the pandemic.
That's great feedback, thanks.
Question from Rick Blackwell. The cost of growth committee can excuse growth that exceeds 3.4% if the excess growth is justified. Would that interfere with savings to be recaptured?
That's a great question. The details and methodology have to be worked out and would be part of the conversations with CMS as well. So good question, good comment. Thank you.
Okay, here. Right, there's a comment or question from Dan Cushing. Would CCOs be responsible for these funds? What is the incentive to CCOs to create savings?
What was the first part of that? I heard the second part, but could you reread the?
I think it was a question about whether the CCOs would be responsible for these funds.
Responsible for the investment part or on the savings side?
Let's see if I can get clarification.
Well, I guess I could answer, but I mean, with regard to the savings side, CCOs are some of the payers that are kind of responsible for the cost growth target, but not the only payer. So it's kind of that statewide. And then with regard to the investments, as I mentioned, we're really looking to the communities to be kind of the lead decision makers with these investment decisions.
Okay, so we've got a comment on addressing the previous question on counterproductivity of short-term CBO grants could be important here. When we talk about investments, should we need to make that a longer-term investment?
Yeah, great point. And the comment, I heard that earlier, and we have heard that many times about needing to ensure sustainability and investment. So looking at a 5-year period here. So at least that's not super short term, but it's a point well taken.
So there's a suggestion to provide grants and contracts and trainings to culturally specific community-based organizations. And a question and comment from John Santa, what about linkages to education, promote health strategies that improve education outcomes?
Yeah, that makes certainly resonates. And I think we are imagining that these investments could,
Oh my gosh, that's how I am.
could beyond the health system and sectors as well. So education makes partnerships with the education system will, I think, undoubtedly be on the list for community needs, or to address community needs, I guess.
Okay. An idea for childcare: can community-based childcare centers be considered? Keeping childcare local makes it walkable, or at least reduces the need for travel and provides work and builds trust in the local community. Okay, and then a comment, your most powerful partners will be peers, community health workers, home health workers, navigators who are working with their own communities. Okay, Chris, I think we accidentally muted you. There you go.
Can you hear me now?
Yes.
Okay. I think those are all comments, right? So I didn't miss answering. Yes. Okay.
Let's see here. And I have a hand up from George. George, let me unmute you. Okay, George, you're unmuted. Please feel free to ask a question.
Yeah. Has anybody on this waiver system considered taking economic drivers from the SHIP State Health Improvement Plan and apply that towards this waiver? There's been a lot of work that's being done on it called the HTO, Healthier Together Oregon.
Yeah, great question, George. Yeah, absolutely. We have, we're working closely with folks, Public Health Division and beyond that are running the SHIP process, and that work will be is reflected in our waiver strategies and will continue to be reflected. So thank you for that comment.
No problem.
Okay, there's a comment. In Lane County, our CCOs invest monthly into primary prevention programs. CCOs contract public health to work with community members, the CAC, on deciding where and how funds are spent each year and managing those strategies. We target communities and regions that need more support, rural, BIPOC, et cetera. So for example, the earlier question about sustainable funding models for parenting programs and social determinants of health, this is a model that works great for CCOs, public health, and the community, and is aligned with our community health improvement plan.
Sounds like a great model. Thank you.
And then there's a question, can we talk about how a real power shift to empowering communities will look? OHA has tons of input from communities over the years and know well who speaks well for their communities, but these people, groups, and organizations are not now truly empowered.
We're going to try to do better, and I appreciate that comment.
Okay. Don't believe I have any more questions or comments from the chat at this point.
Okay, thank you.
Okay, alrighty. So thank you, Chris. On our agenda, we have actually this time slated until 3:25, but we do have a quick wrap up and a break scheduled before the additional Q&A session begins. Let me just double check and make sure that there are no pending questions before we potentially take a break a little bit early. And I don't have any additional comments. So we'll go ahead and wrap up before the break. So in terms of next steps on how to stay involved, this was the first of a 3-part series. So you can stay informed about progress and review the concept paper drafts, which will be released on June 3rd. The website there is oregon.gov/1115 waiver renewal. And I'll also put that back into the chat box for folks. You can submit comments and questions and any feedback related to the waiver to the inbox, the email address posted on the presentation. And the next workshop session, we will have a date posted on our website for the next session on June 2nd, and our goal is to also send that information out via email to anyone who's registered for today. So if you don't remember to check the website, we will send that email to you about the date and details about how to join the next session. So I will double check just to make sure we don't have any outstanding comments. Okay, so at this point, we'll go ahead and wrap up. We have an additional Q&A session that is completely optional for anyone who did not get questions answered. Some of them, like I said, if we don't have a response for you today, we will post those for you by next Friday, which would be June 4th. Again, at the website that's up on your screen now. So we will go ahead and take a break, and we will return here for the Q&A session. That will include Lori Coiner, our Medicaid director, at 3:35. It's 3:10 right now, so folks can take a little bit of a break. Feel free to exit the presentation. We will readmit everyone, or you can stay logged in. We'll leave the presentation up. We'll also be emailing the presentation out at the end of today so that you can have it available, and we'll be posting it on our website. So we will go ahead and take a break and see you all back here if you would like at 3:35. So we're going to go ahead and jump into our optional Q&A session. That includes our Medicaid director, Lori Coiner. And let me just make sure that everybody is unmuted. So as a reminder, this session is being recorded. The recording will be available on our website after this presentation is over. We will email out some additional information about how to access that, I believe, tomorrow. As a reminder, a couple of options for submitting questions. You can send them to the chat, which will go directly to me, and I'll read them aloud to the group. You can also raise your hand, and we will unmute you so you can ask the question directly. And I don't see any pending questions at the moment, but let me just double check here. Okay, Lori, have you rejoined us? Okay, it looks like we have Lori back. Okay, so there are a couple questions that we were not able to get to during the presentation. Lori, are you able to speak? Are you unmuted? Yes, we can hear you. Okay, Lori, can you hear us? Okay, apologies everyone. Seems like we're having a little bit of technical difficulty. Okay, everyone, just 1 second while we get this figured out on our side. Okay, apologies everyone. We're going to have her close out and try to reconnect to the presentation in just 1 moment.
Hello, this is Lori Coiner. Can you hear me?
We can.
Oh, yay. Okay. I can now.
Fantastic. Okay, so welcome everyone. Sorry for the technical difficulties. We have with us for this extended Q&A period, Lori Coiner, who is our state Medicaid director. We had several questions that we were not able to answer during the presentation. So the goal of this period is to provide a little bit of an extra chance to have some discussion. So the first question that came up that we didn't get the chance to answer was, will CCBHC be included in the waiver?
No, we don't have a plan to include the CCBHC work. However, in the bills that are working their way through the legislature right now, I do believe there's funding for CCBHCs through that mechanism. So we don't anticipate needing to include them in the waiver since they will be funded through the state legislature.
Great, thank you. And as a reminder, any questions can be entered into the chat and sent directly, or if you would like to raise your hand, I can unmute and you can ask the question directly. So the next question, what will be the fraud, waste, and abuse oversight for self-attested enrollment?
For both What was the first?
What would be the fraud, waste, and abuse oversight for self-attested enrollments? I'm assuming for some of the public health emergency extensions on redetermination.
That's a good question. On the self attestation for enrollment, that's something that we're doing now as part of COVID. We found that it's an authority that we received through the federal government because of the public health emergency. And we found that it has drastically reduced the time it takes for a potential member to enroll. What that means, but I want to be clear that we do end up checking the, verifying income. We can do some through federal systems, and then we would get back to the member at some point. It's just they don't need to provide, for example, a pay stub right at the time that they're enrolling. And then, so we would be still doing some sort of income verification at a later date.
Okay, thank you. Next question is, what actions are being considered to increase the number of providers with cultural competency and those with specialties where a shortage exists, for example, child psychiatrists?
Yes, but that's a important question. So there are a couple different ways. One is, again, in the legislature, there is a request by OHA to develop workforce. It's mostly focused on behavioral health. Well, it's solely focused on improving the behavioral health workforce. And that includes both just the numbers, because we have a behavioral health, so meaning mental health and substance use workforce shortage throughout the state. That's especially a problem in rural parts of our state, but it's all over. And then on top of that, to have a more even bigger focus on expanding the workforce that is culturally and linguistically appropriate for our communities of color. So if all goes as anticipated, the legislature will be providing significant general fund dollars to build that programming within OHA. We also are looking at, when Chris DeMars presented on some of those shared savings, or thinking about potential funding that would be system-wide, it would be to provide, a more focused attempt to develop a culturally appropriate workforce. We're just not sure whether that's going to be needed after we see what happens with the legislature and that funding. So we will add it if we think there are ways that we can make that expand or amplify what the bill the bill that's going through the legislature now, and if not, then we'll use those funds in other ways.
Okay, next question. Can Oregon get a waiver to reimburse certified mental health counselors beyond certified social workers to provide mental health services in rural areas where there is a shortage of mental health services?
That's a good question. And it's certainly something that we could explore. In our substance use disorder waiver that was just approved, one of the pieces that Center for Medicare and Medicaid Services did not approve was peer support services. And the reason is that we couldn't come to agreement with the feds on oversight. So, clinical oversight of those peer support specialists. And CMS cares a lot about making sure that, while workers are at the top of operating at the top of their license, that they have whatever the required clinical supervision is. So those are some of the things that we can take a run at again when we go back to our 1115. I know that peer support is especially culturally appropriate peer support is really important. So people from the community with lived experience offering peer support is something that we'd like to see. We could also look at it in terms of some waivers, some of those kinds of oversight requirements for other parts of the workforce.
Thank you. And the next question, will there be an IMD waiver for mental health residential settings similar to substance abuse residential settings? IMD stands for Institute for Mental Disease.
Yeah, that's a great question. So the Center for Medicare and Medicaid Services did authorize states the ability to apply for an IMD waiver for mental health. We did receive one for substance use disorder. And we took a look at it, and one of the difficulties is our average length of stay, you know, for IMDs in Oregon are too long to qualify. We can relook at it, but I think because most of our IMD stays are at the state hospital, the timing doesn't work for us to make that request. So that's why we haven't so far. You have to have your average length of stay for the IMDs be pretty short in order to make it work out.
Okay. Next question, can a waiver allow interpreters to be providers for the purposes of billing?
Oh, that's an interesting question. I don't know. I've never heard of that, but we could certainly look into that. Megan will have to just capture that as something to look into.
Okay.
I don't believe that if a person is offering interpreter services and not clinical services, that they could be considered a provider. But we could take a look at it.
Okay, thank you. Okay, let's see, the next question. Will there be a proactive strategy for transparency throughout the waiver process? This is a good start, but the condensed time span might cause some activities to lose their priority.
I'm sorry, Megan, can you repeat that question?
Sure, I think it was a question about the waiver development process. Will there be a proactive strategy for transparency? And the concern was that because of the condensed time span, maybe the goal of transparency might not be as much of a priority.
Yeah, that's a very good question, and I appreciate it. So our time frame is limited, and it's tough with the restrictions around gathering with COVID, or it has been especially. And we have to submit our application no later than December 31st. So we've been really looking at how to engage the broader community, you know, in the work and getting feedback like today. We also, our community partners, the CPOP teams holding webinars that are open to the public as well. And we will have another one or two of these. But I think what's important is this idea. So I do believe we have lots of avenues to get feedback, input and feedback on our kind of on our concept papers and throughout the process. And there is a formal public feedback process that happens at the time that the waiver's completely you know, written up. We have to post it for a period of time, and there's opportunity for public feedback then. But what we have been talking about as a team in terms of transparency is not only how do you make it times available for people to provide input, but then also how do you communicate out what was included and what wasn't. Megan and her team are working really hard to come up with a process on that. We are getting huge amounts of information from the public and from partners. And then, you know, as we go through, we're looking at how to provide that information back. I can't say at this point that I have a process nailed down, and Megan may want to chime in on it. but I can say it's forefront in our minds on figuring out how to do it so that, that we're open about what we heard and then what we were able to include in the waiver and what we didn't include. So Megan, do you have anything to add, or is that?
Yeah, I can offer. And like Lori mentioned, we're still figuring out the process for how that information gets posted, but it is absolutely our intent to provide visibility into what feedback we received, kind of what went into the decision, and then what was ultimately, the rationale for why a direction was chosen over the other. So that's been a pretty common theme that we've heard from folks around feedback that we've received in the past. So like I said, this is a pretty big priority for us to make sure that folks are aware of what we did here and ultimately the reason why we chose to go in one direction or the other. Okay, the next question on here, I'm not sure if this is maybe more of a Jeremy question. How will the pending recommendations of the 770 task force inform the waiver proposals? They are due to the legislature at the end of June.
So I I'm really lucky, and Jeremy has joined us again, and I'm going to Jeremy.
Thank you. So for folks who don't know, the Senate Bill 770 task force is a task force set up a couple years ago to look at universal coverage and moving towards a single payer healthcare system. Basically, as those conversations move forward, as conversations in the legislature move forward around funding Cover All People or passing legislation around public option, we'll just need to bring all those together this summer as we're looking at what our long-term strategy is around universal coverage. So we'll certainly be looking at other recommendations for other bodies of work or legislation that passes that touches on universal coverage issues.
Okay, next question. Will OHA be assisting counties that currently do not have health equity coalitions informing them?
So there is legislation right now that I think is going to move forward that would establish a regional health equity coalition in all parts of the state. So we're certainly hoping for that. The other place where we're obtaining information from all parts of the state is through our community partners. They are working all over the state, and that we're having 3 webinars with them.
Great. Let's see here. So this is more of a recommendation or suggestion. There are a lot of people who are OHP eligible but do not enroll and also have children in school. It would be helpful to have OHP liaisons in school to promote enrollment.
Yeah, that's an interesting idea. I think that's something that we could float with the CPOP team.
Okay, another recommendation, CCO wait times can be up to a month to see an out-of-network clinician. Client choice should be honored quicker. And then a question around how were communities of color involved in this problem solving and waiver development process?
So the out-of-network, I think we'll have to deal with directly with CCOs. That's not a waiver issue, but rather communication with the CCOs around obtaining approval for out-of-network services. In terms of communities of color, let me start in, and maybe Jeremy can add. So first and foremost, we've heard from communities that they're tired, that COVID has been, and rightly so, focused on the COVID response for their communities. And so one of the things that we did was take a look at what we've heard from community through the CCO 2.0 process, through COVID processes where we receive feedback from communities, and the state health improvement plan process, and numerous other kind of processes that we've had over the recent years. and compiled that and took a look at what the themes were around, where communities had cared and areas that were important to communities around the state, with a focus on communities of color. So that's been incorporated in what we've developed so far. The other pieces, we are engaging with the Regional Health Equity Coalition on the 3353, their bill that's going through, or the bill that they've had input on that's going through the legislature now. And so we're continuing to talk, we're talking to them now about how to incorporate those pieces in the waiver. The other piece is that we're meeting regularly with the Governor's Racial Justice Council Health Equity Committee. They are focused on legislative agendas and some other things, so we're just keeping them apprised. We're hoping to have a waiver discussion with those members of the Health Equity Committee on the Regional Justice Council for anyone who's interested to get feedback. And then we have engaged the Oregon Health Policy Board Health Equity Committee, and they're providing policy oversight. So they want to take a look at what feedback we got from community and incorporated. We are doing a health equity assessment of the waiver, and we'll be providing that assessment results to the Health Policy Board so that they can advise us on, places that we need to improve on that. So those are some of the strategies, or the main strategies, that we've used to include the voice of communities of color in the waiver.
Okay, so we don't have many more questions. Just as a reminder, please put any questions that you have into the chat. We're happy to read them aloud, or if you'd like to raise your hand, we can unmute. One question: how robust is the community assister workforce? Many people would benefit from in-person assistance when applying.
I'm sorry, Megan, I didn't catch that. How robust is the
community assister workforce?
Oh,
The application assister.
yep. No. In terms of, if you're talking about community assisters for getting enrolled, that's our community partners team, and that's very robust. We've got people all over the state, and we've got lots and lots of hundreds of organizations that are involved in that. If it's in terms of a clinical settings, I think that isn't robust at this time. And I don't know, Jeremy, if you've got anything to add.
No, I think that's an ongoing conversation we need to have around what are the current resources and what else is needed. As we talked about during the coverage piece, a lot of folks are actually eligible for either marketplace or Medicaid coverage, but not enrolled. A lot of the uninsured. So I think part of what we really need to understand is some of this isn't actually about changing eligibility. Some of this is about the infrastructure resources for outreach and enrollment, and thinking about how do we reach hard to reach populations, and once we get folks enrolled, how do we keep them enrolled, and not have to have them fall out and then need to go try to find somebody again and provide that continuity. So I think we're in need of feedback and input on what additional resources or infrastructure is needed to be able to reach hard to reach populations.
I'm just checking to see if we have any unanswered questions. Let's see. So one was around some of the equity objectives and reporting. So the question is it possible to insert some of these reporting requirements into the waiver? So often it seems like the issue is with enforcement and oversight. If they were built in the waiver, could it trigger more oversight for OHA to deliver on?
I'm sorry, I didn't hear all that again. for whatever reason, I'm just having a hard time hearing.
It's okay. So this was related to some of the equity goals. The question is it possible to insert some of these reporting requirements into the waiver? So often it seems the issue is with enforcement and oversight, but if they were built into the waiver, could it trigger more accountability for OHA to deliver on?
Yeah, let me comment on a couple pieces of that, and then Jeremy can weigh in as well. So one of the things that we are doing is looking at our metrics program and how we hold the CCOs accountable through our quality metrics program. And so there may be some potential there to think about how to pay for performance on equity. The other place is we do hold in our current contract with CCO 2.0, the CCOs are completing an equity assessment, and they're required to report on that and show improvement across time. So we do have some accountabilities built in around the CCOs and looking at how to do that in the waiver as well. The final thing is every waiver has to, and Jeremy mentioned this, if you went to the 101, waiver 101 part, all waivers have to have a formal evaluation. And because our waiver is going to be focused on equity, that evaluation will certainly look at how we've moved equity in the future. So those are I think the ways that we're thinking about, accountability, but certainly open to other ideas. And Jeremy.
Well, I would just add that part of the negotiation with CMS is, when we submit our application, they actually will look at it and say, this we think requires a waiver, this doesn't actually require a waiver, and they'll actually kind of push stuff out that isn't required. So there's stuff that's in kind of in a gray area, certainly, but that is part of the discussion with CMS is they actually, things that don't actually require a waiver, they will ask us to try to address outside of the waiver often.
Okay. We have a question from Cassandra, who's raised her hand. Cassandra, I've unmuted you. Please feel free to ask your question. Not hearing anything from Cassandra. Let's see. Nope, we can't hear you just yet. Okay, let me see if we can move on to some other questions while we see how we can help her. So I'm actually not seeing any additional questions. Oh, we've got one more, sorry. What waiver funding and investment opportunities or concepts are being formulated to increase equitable and improved access to substance use disorder and mental health across the lifespan, both within fee-for-service and CCOs?
I'm sorry, I didn't catch the beginning part of that.
What waiver funding and investment opportunities or concepts are being formulated to increase equitable and improved access to substance use disorder and mental health across the lifespan, both within fee-for-service and CCOs?
So as I've mentioned a couple of times, in the legislature right now, there's a number of bills that request significant funding for behavioral health. So we expect to see more dollars coming to the behavioral health system. We also put in a request, which I believe will be I'm hoping will be funded, and that was a request for funding to provide more resources so that we can operate our fee-for-service program, our open card program, like we do a CCO, and have more accountabilities there. And as people move, if they do move between fee-for-service or they stay in open card, that they have the same opportunities as people who are in CCOs. In the waiver, really what we're talking about in terms of behavioral health pieces are the transitions of care. So we haven't looked at it across the lifespan, you know, in terms of adding any pieces to the waiver. We do believe that this additional behavioral health funding will help, you know, bolster a lot of that work. And there are provisions in some of it around the kids program as well. So I think it's going to come through the legislature and the behavioral health program, and then we'll be adding pieces to it with the waiver. But a lot of that wouldn't require waiver authority.
Okay, so we have just one remaining question and one hand up. Paula Ferguson, I've unmuted you. Please feel free to ask your question. Paula, we're not able to hear you. Paul, so I would ask if you can send your question into the chat or into the inbox. We've just got one more question. This one is around transportation services for clients going from Medicaid to Medicare. The ask is if this could be part of the waiver plan to provide Medicare clients some type of transportation benefits, I assume if they're dual eligible.
We don't have that in the waiver. Typically, unfortunately, the waiver is for Medicaid only, and so we won't be, we aren't able to offer services or include any services that are related directly to Medicare. Now, for dual eligibles or people who are covered both Medicaid and Medicare, we do have the opportunity. And I believe that dual eligibles already are eligible for non-emergency medical transportation services. We haven't looked into additional transportation, and if we do add that, then that would be, you know, they would be included in that.
Okay, everyone. Doesn't look like we have anything more pending. We do have a couple different ways for you to send questions or feedback if you still have it or think of something after the session. We've got our inbox, which I will put the email address into the general chat. And also you can visit the oregon.gov/1115 waiver renewal webpage, where you'll have some additional information about where public presentations will be held and the next presentation for this type of session. We'll post that information on June 2nd. Thank you everyone for attending. I think we'll go ahead and wrap up early since we don't have anything else. Appreciate everyone's attendance. And as I mentioned, we will send some of that information out by email so that you can register for the next event once we have it scheduled. Thank you, everyone. Have a great afternoon.